Okay, so welcome to the part 2 or the second tutorial of our GMDC internal medicine. All right, so let us begin. So we have a young girl with her mother visited your facility with a progressive hair loss over her scalp, which started few days ago. On examination, you notice a ring-shaped rash with a raised edges and a central clearing on the scalp. So this is like, if you watch the previous video, right, that this is like alopecia again, okay? But now they want to know the specific type of alopecia, I believe. So now they've given you what? There is a presence of a ring-shaped rash with raised edges and a central clearing on the scalp. So what comes to mind? What comes to mind? That's what you need to be talking about. So definitely you might be looking at something about tenure capitis, isn't it? Because of the presence of this ring-shaped rash, and hence we call it the ringworm. Ringworm. Yes, exactly. So that's what we're looking at over here. So what is your provisional diagnosis? Definitely, you are thinking of tenure capitis. Tenure capitis. All right. Two differential diagnoses. Diagnosis. So over here, you can think about psoriasis, then seborrheic dermatitis. These can be your differential diagnosis for tenure capitis. All right. What medication will you give to treat this condition? What medication will you give to treat this condition? Don't forget, this is more or less like a fungal infection, isn't it? Ringworm is a fungus. It's caused by a fungal infection. So definitely, you can going to give what? An oral antifungal drugs. Like the itraconazole, fulvin, and so on and so forth. Then you can also give some shampoo or ketoconazole sort of shampoo. Then sometimes you can give prednisolone. This is an immune suppressant, isn't it? So you can give that one as well. So basically, oral antifungals, ketoconazole, then prednisolone. These will be your medications. All right. What advice will you give to her mother in preventing this condition? What advice are you going to give? Like I said, this is caused by a fungus, isn't it? So fungal infestation. So in general, you talk about fungal infestation. And you know, in fungal infestation, mostly it affects the foot. So basically, you're going to keep the feet clean and dry. You keep the feet cool by taking your shoes off or wearing sandals as often as possible. Okay, because it doesn't like heat. Then you have to avoid wearing heavy clothes shoes or thick socks. You have to rotate the shoes you wear and don't reuse socks without washing them first. Avoid using swimming pools and public showers because these could also be infected. And avoid close contact with infected persons and animals, especially dogs and cats. And avoid sharing of objects like towels, hair brushes, or combs. Because if the next person is having it, comb the hair, you take it and comb your hair, perhaps you can also get it. So avoid sharing such objects. Then proper hygiene. So practice proper hygiene. So these are the preventive measures you can, or the advice you can give to the mother in preventing this sort of infection. So basically, that is it. All right. So name the causative organisms. Like I said, this is covered about the fungi. So definitely you're going to mention the species that could cause this. So you can talk about trichophytin species, microsporum species, epidermolysis species. Species. So these are the causative organisms you are going to be mentioning. Trichophyton, Microsporum, Epidemophyton, or phyton, any way you want to pronounce it. Okay. Now, an elderly man presented with an inability to urinate. An elderly man cannot urinate, okay? Pain during urination. Temperature is high, chills, nausea, and you notice a swollen and tender prostate on digital rectal examination. From his anamnesis, he has a history, guys, history of hypertrophy of the prostate gland. Again, anytime you look at something like this, always look at the history. So if it doesn't have a history of a disease, think of a possible complication. Possible complication. But you see, this person is also coming with what? Cannot urinate, temperature. So sign of what? Intoxication is present, isn't it? Chills, nausea, temperature, and so forth. So definitely you are thinking of what? Possible infection. Possible infection. That is causing the urine not to come out. So we're going to be looking at it briefly. So what is the most likely diagnosis? What is the most likely diagnosis? And over here, we are going to look at for what? Acute bacterial prostatitis. Acute bacterial prostatitis. Like I said, you are thinking of what? Some sort of infection that could block the passage of the urine. Or someone can say this is acute urinary retention secondary to acute uh, bacterial prostatitis. Acute bacterial prostatitis. So acute urinary retention secondary to that. And you can be correct, isn't it? Because if you have a history of BPH or hypertrophy of the prostate gland, it can lead to what? A possible infection over there. So, two differential diagnosis. So, what could be your differential diagnosis? What could also be the cause of this? Definitely, you could think of what? BPH, benign prostate hyperplasia. BPH, benign prostate hyperplasia. You can think of prostatic cancer. Prostatic cancer. You can think of urethral stricture. So anything that blocks the flow of urine, urethral stricture. You can think of acute prostatitis, acute prostatitis, acute prostatitis. You can think of prostatic abscess, prostatic abscess. So any two, and you are okay to go. Just any two, any two. All right. So again, benign prostate hyperplasia, prostate cancer, acute prostatitis, urethral stricture, prostatic abscess. How will you treat? How are you going to treat this person? Definitely, you are going to pass a urethral catheter. You're going to pass a urethral catheter so that the person can pee through. You're going to give antibiotics. Then, of course, bed rest. So again, urethral catheterization, antibiotics, bed rest. Bed rest. All right. Your investigations. What investigations are you going to do? So of course, there's no way you can forget what? PSA. There's no way you can give out PSA. That's what prostate specific antigen. PSA. PSA. And usually when it is less, in general, PSA level is less than 4. It's less than 4. So if it is normal, it is less than 4. But if it is greater than 10, then we must be afraid. We have to do other labs again to confirm what we are looking for. Okay. And usually when you have sex, okay, your prostate, your PSA levels normally increases. But after some time, it will come back to norm. Okay. But when this level is persistent without any sexual stimulation and then, it's still high like that, then we might be considering a problem. All right. So apart from the PSA, you can also do full blood count. You can do post-void urine. Post-void urine. You can do your blood culture. You can do your blood culture. You can do your urine culture and sensitivity. You can do your urine analysis. So again, urine analysis, urine culture and sensitivity, blood culture, post-void urine, full blood count, PSA. PSA. So these are the investigations you might want to consider when dealing with people like these. All right. And of course, if you're suspecting a cancer, you might want to do a biopsy. All right. Now, a 10-year-old patient whose mother is hypertensive, 10 years old, mother is hypertensive, came to your facility for a medical checkup. So that means the person is not sick, just coming for medical checkup. Now, an examination, there was an increased blood pressure, more than 20 millimeter mercury in the right arm than the left. Okay. Also, the blood pressure in the lower extremities are greater than those. Okay, I think the blood pressure in the higher extremities, this is higher, not lower. In the higher extremities, that is the upper arm, in the higher extremities, are greater than those in the lower extremities. So you and I know that your BP is supposed to run throughout your whole system. At least it should be normal, isn't it? But here's the case: some part of your body is higher than the other. Your upper part is greater than the lower part. So what could possibly be the reason of that? And usually it occurs when there is a narrow of the aorta. Okay, when there is a narrowing of the aorta. Now, talk about narrowing, we might be looking at a term called coarctation. It's more or less like narrowing, okay? But with the way it comes with, we will not call it narrowing, but we'll call it what coarctation. But technically put, it's the same as what narrowing. So these are some of the things or the conditions that can lead to differences in blood pressure. And again, these normally occurs around where the arteriosus, ductus arteriosus is. The ductus arteriosus. I believe by now you should know what the ductus arteriosus is all about. So around that area, that is where sometimes you can find this sort of what narrowing of the aorta. And it can be before or after the ductus arteriosus, and all of them have their own name. But let's quickly go through the questions over here. Then we'll analyze it. So what is your likely diagnosis? Definitely, we are looking at what? Coarctation of the aorta. Coarctation of the aorta. And again, there's narrowing of the aorta usually after the left subclavian artery or either before or after the ductus arteriosus. Okay, either before or after the ductus arteriosus, but it must be after the left subclavian artery. After the left subclavian artery. And usually when you draw the aorta, aortic arc, something like this, you might be finding the left subclavian over here. Then perhaps the right subclavian is this place. And around this same area, we might be having the ductus arteriosus. The ductus arteriosus. So coarctation occurs around this place or after this place, basically. And you see, this place will supply the upper arm of the body. I mean, the aorta here will supply the upper arm of the body, whilst after the narrowing or after the aorta, after the ductus arteriosus, we might be having the one that will also supply the lower limbs. And that's when there's a blockage over here. When there's a blockage over here or over here, it leads to problems in the lower extremities. All right. So this is what coarctation of the aorta. Now, what type of this condition do you know? Already I've mentioned it. We are talking about what? Two types. So over here, we'll be dealing with the preductal coarctation of the aorta. Preductal, that means before the ductus arteriosus. It is also called the infantile. That means it is very, very common in children or in infants. infantile. Infantile. So over here, the narrowing is between the subclavian artery and before the ductus arteriosus. So that is what the preductal or the infantile. Then you can think of what the adult or the postductal. Postductal. That is narrowing that's occurring after the ductus arteriosus, and this is common in adults. So again, preductal and postductal. All right. 3 diagnostic features likely to be present. 3 diagnostic features. That means if somebody is having coagulation of aorta, what are the things that you must see or you must, check out for? And one, diminished femoral pulse. Diminished femoral pulse. That's over here. The blood pressure in the upper extremity was higher and it was greater than those in the lower extremity. So definitely you're going to use the femoral pulse to measure this kind of pulse. So the femoral pulse will be diminished. There will be what? Heart murmur in the left infraclavicular area. Heart murmur in the left infraclavicular area. Good. Then you will see a prominent suprasternal notch pulsation. Prominent suprasternal notch pulsation. You can think of aortic stenosis. You can think of abnormal breaths. Abnormal breath. So again, diminished femoral pulse, heart murmur in the left infraclavicular area, prominent suprasternal notch pulsation, aortic stenosis, then abnormal breaths. So these are the diagnostic features of coagulation of aorta. So any 3 of it, and you are okay to go. 2 investigations you will do. 2 investigations you will do. Definitely, this is a problem of the heart, isn't it? So you might want to do what? An echocardiogram. Sorry. You might want to do echocardiogram. Then you might also want to do what? The chest x-ray. You might want to do the chest x-ray. And again, you might want to do what? ECG. So these things, you can do them. And the reason why you have to do the echo, again, will help you to know the localization and the severity of the coagulation or the aortic coagulation, because in echo, you're basically dealing with what? With the valves. You are dealing with the valves, the passageways. You are dealing with the valves. So you want to look at all of these things that, will help to know what is really wrong with the patient. Then the ECG and then the chest x-ray. All right. 3 possible complications of this condition. Possible complications, the outcome, the consequences when coagulation of aorta is not treated properly, or you don't give it much attention. What are some of the complications? 1, you can think of aortic aneurysm, hypertension, cerebral aneurysm, paralysis, cardiomyopathy, chylothorax, CHY, chylothorax. So where there's what? A lymphatic flow disorder. So this can lead to what? A lymphatic flow disorder, which of course can affect the lungs and the chest wall. Good. Then we can also talk about what? Post-quactectomy syndrome. Where there's what? Severe abdominal pain after surgical resection of the coagulation of the aorta. Severe abdominal pains after surgical resection of the coagulation of aorta. So we call it post-quactectomy syndrome. All right. So basically, these are the possible complications you might want to be looking out for. Again, aortic aneurysm, hypertension, cerebral aneurysm, paralysis, cardiomyopathy, thorax, and then post-quackectomy syndrome. All right. Name any defect associated with this condition. So, what other defects can you be looking out for when a person having what coarctation of aorta? Definitely, you can't forget your ductus arteriosus. So, you can have patent ductus arteriosus. Patent ductus arteriosus. That means it will still be what? Opened. Then you can have ventricular septal defect. Ventricular septal defect. You can think of aortic stenosis. Aortic stenosis. So these are the associated defects in people suffering from coarctation of aorta. Again, patent ductus arteriosus, ventricular septal defect, aortic stenosis. All right. Good. Now we are having an elderly woman with a history of hypertension, HPT, was found lying on the floor. Although conscious, she is unable to talk nor stand on her feet. Again, there's a history of hypertension. So think of the possible complications of hypertension that could possibly lead to inability to talk nor stand. So that means you are thinking of a problem relating to the brain. So it could be stroke, isn't it? Something like that. All right. So what is the likely diagnosis? Definitely, you are thinking of what? Stroke or CVA, also known as cardiovascular accident. Cardiovascular accident. So CVA. CVA. I remember when I came to a film contact, they were mentioning CVA. I'm like, what is CVA? I'm not used to the word CVA. But it's the same as what? Stroke. With time, I got to learn that it's the same as stroke. All right. And it's very, very common in Ghana. So please take note. All right, so you must know everything about stroke. Trust me. Try and read extensively on this topic. All right. What types of this condition do you know? So types of stroke or types of CVA, mention them. Definitely, there are two types, hemorrhagic stroke and ischemic or infarctive stroke. Infarction means ischemia, isn't it? Or ischemia leads to infarction. So sometimes you can say ischemic, but sometimes you can also say what? Infarctive or infarction. So we have two types, hemorrhagic and infarctive or ischemia or ischemic stroke. So these are the two types of this condition. List important history you will look at for. Important history. So basically, you're going to be looking at what? Risk factors. Of course, you have history of what? Hypertension there. You can talk of, or you can look for history of diabetes, history of heart disease, then history of high lipids, or even obesity as part of the history. You're going to look if the person is obese or not. So again, hypertension, diabetes, heart disease, high lipids, and of course, obesity. These are the important history you will be looking at for in this patient. What important physical findings will you look out for? Physical findings. Physical findings. So under physical findings, you are going to be looking at for what? Loss of consciousness. Loss of consciousness. Facial palsy. So somebody having stroke. What are some of the things you're going to see? That's what I'm mentioning. Loss of consciousness, or the level of consciousness will be reduced. Facial palsy, dysphasia, or the same thing. Dysphasia or aphasia. Good. Dysphasia or aphasia. Then pulse arterial fibrillation. Pulse arterial fibrillation. Blood pressure. Presence of murmur. Then there'll be weakness in the tone, the power, and reflexes. And the motor system will also be weak. So again, what are some of the physical findings? The level of consciousness, the facial palsy, aphasia or dysphasia, pulse arterial fibrillation, blood pressure, presence of murmur, motor system weakness, tone and power, reflexes will also be weak. So these are the physical findings you might want to look at for in this sort of patient. What single most important investigation will you do? Guys, look at the question. What single most important? Don't go and be mentioning any supportive sort of investigation. Mention the main one. And the main one for diagnosing stroke is head CT or CT scan of the head. Head CT or CT scan of the head. All right. 4 risk factors. Risk factors for stroke. Risk factors for stroke. This you can say is more or less the same as the history that you're looking out for. Like I said, it all means what? Risk. So again, hypertension, diabetes, AFib or atrial fibrillation. Atrial fibrillation can also lead to stroke. Now, why atrial fibrillation can lead to stroke is that when there's that kind of thing going on there, fibrillation going on there, they could lead to what? Or it could lead to clotting. And those clotting can go and block some part of the brain. That's what I mean, where blood will not be able to get into the tissue, and that can lead to what? To stroke. And that's usually we give anticoagulant as well. With people suffering from even stroke, we give them anticoagulant. This helps a lot, like aspirin. Usually, that's what we add to it, aspirin. All right. So again, hypertension, diabetes, AFib, then hypercholesterolemia. All right. Or too much cholesterol in the blood. Okay. All right. Good. So a young male visits your facility with a 3-day history of generalized swelling. Guys, the whole body is puffy. He complains of a swollen face on waking up, which reduces at the end of the day. At present, also present is a distended abdomen. Also present. That means ascites could be here. So we have ascites, we have generalized edema, we have facial puffiness or facial swelling, which most definitely what comes to mind. You are thinking of probably a kidney problem, isn't it? Yeah, probably a kidney issue. Good. So let's look at the questions that we're having here. But before that, let me tell you these things. Usually when someone comes to you with edema, okay, edema, we have, let me just say, 4 basic organs you need to be looking out for, or systems you need to be checking out for. So 1 will be the heart. 2, you can think of the liver. 3, the kidney. And 4, the GIT. Again, heart, liver, kidney, GIT. When you think of any edema, think of these organs. Think of these organs. Because these organs, when there's a problem there, immediately edema will start forming. But for this question, let's look at what we are having over here. We are having what? Generalized swelling, and then with puffy face, which goes off at the end of the day, then the standard abdomen. So over here, with the fact that there's a generalized body swelling, the term is called anasaka. So what is your likely diagnosis? Anasaka. And this can be secondary to nephrotic syndrome or chronic kidney disease or chronic kidney injury. Again, there's anasaka, which can be secondary to nephrotic syndrome or chronic kidney disease or chronic kidney injury. All right. But again, just your likely diagnosis is what? Anasaka. 5 differential diagnosis. Okay, so what can lead to all the kind of edema in the body? 1, you can talk about nephrotic syndrome, which has to do with the kidney. Okay, because I mentioned that think of kidney, think of liver, think of heart, and then the GIT, isn't it? So now let's put them into perspective. So we can talk about what? Nephrotic syndrome. We can talk about chronic kidney disease. We can even talk about nephritic syndrome. So all this related to the kidney. All of these can lead to edema formation. Again, nephrotic syndrome, chronic kidney disease, nephritic syndrome. So let me just give you a little bit of assignment. Give me the differences between a nephrotic syndrome and a nephritic syndrome. Nephrotic syndrome and a nephritic syndrome. So kindly write it in the comment section under the video. Nephrotic and nephritic syndrome, the differences between them. At least give three each. All right. So this refers to what? To the heart. Sorry. That's the kidney, isn't it? Now let's come to the liver. We can think of what? Liver failure or liver cirrhosis. Liver cirrhosis can lead to edema formation. Liver cirrhosis. Let's think about the heart. We can have a congestive heart failure. Congestive heart failure that can lead to edema formation. Then with the GIT, we can think of malnutrition or protein losing enteropathy. Protein losing enteropathy. Lastly, but not the least, which is not doesn't fall under the category I've mentioned, you can think of what? Allergic reaction. Because allergic reaction can lead to what? Edema formation. So again, nephrotic syndrome, chronic kidney disease, nephritic syndrome, liver failure or cirrhosis, congestive heart failure, allergic reaction, malnutrition, protein losing enteropathy. These are 5 differential diagnoses, or these are your differential diagnosis. So investigation will you do? What investigations will you do? Investigation, of course, you are thinking of what? Chronic, because this is very, more likely to be what? A nephrotic syndrome, okay, or chronic kidney injury, more specific to these areas. So what investigation will you do? Definitely you have to do what? A urine analysis or urine dipstick. And what are you looking out for? Proteins. Protein, because in nephrotic syndrome, I'm not mention it, but in nephrotic syndrome, you're going to have a lot of proteins in the urine. Okay, a lot of proteins in the urine. Then you can have low albumin because the proteins are being lost. So the albumin level will be what? Will be low. And albumin level is what maintains the oncotic pressure of the blood or the body. Okay. So over here, we're looking at what? A urine dipstick. So your protein will be 3 pluses, because there'll be a lot. You're going to do the biochemistry. So serum protein will be low, especially the albumin will be low. Albumin will be low. Then you can have a normal cholesterol level or high cholesterol level. Normal cholesterol level or high cholesterol level. Then you can also do an abdominal ultrasound for the ascites. Abdominal ultrasound for the ascites. You can do BUE creatinine. Then with the liver, you can do the liver function test. You can do chest X-ray. You can also do a 24-hour urine protein. I forgot that. 24-hour urine protein, which could be more than 3. Sorry, more than what? More than 3 grams per deciliter. Good. So again, urine analysis, 24-hour urine protein, biochemistry. I think serum protein could be low, albumin level to be specific, cholesterol level could be normal or high. You do an abdominal ultrasound for ascites, BUE creatinine, liver function test, chest X-ray. So these are the possible investigations you might want to consider. Signs and symptoms. Please, this is 2-in-1 question. What are the signs and what are the symptoms of the above diagnosis? So let's tackle with what? The signs. What are the signs you want to see? Signs, not complaints. Signs you see. Symptoms refer to what? The complaints. Okay. But sign, what do you see? You will see pallor, jaundice, white nails, soft pitting pedal, presacral edema, periorbital edema. We can have ascites, or you can see ascites. And ascites, you for chest purposes, you are looking at what? Fluid trail, shifting dullness, abdominal tenderness, distended abdomen. That is just on ascites alone. So on ascites, what you can see on examination, you can see is fluid trail, shifting dullness, abdominal tenderness, and a distended abdomen. So these are the signs you can also see under ascites. But the BP could be normal. BP normal. Then, now imagine a lot of fluid in your body. You can also see what? Pleural effusion. Or you can start thinking of pleural effusion as well. So again, pallor, jaundice, white nails, soft pitting pedal, presacral edema, periorbital edema, normal blood pressure, pleural effusion. And under ascites, you can talk of fluid trail, shifting dullness, abdominal tenderness, and a distended abdomen. So these are the signs. So mention as many as you can remember, as simple as that. Now let's see the symptoms. What do the patient complain, or what do they come in with? They will come in swelling of the body. They tell, well, my body is swelling. Yellow eye color, abdominal pains. Their urine volume could be what? Could be foamy. Could be foamy. So they could have what? A foamy urine. Foamy urine. That's because of the presence of the proteins, anyways. They can have difficulty in severe cases. Difficulty breathing in severe cases. Difficulty what? Breathing. They can also have what? Difficulty lifting the arms. Increased heart rate. Their joints could be aching. Joints could be aching. Now, if it is complicated, we can have chest pain, shortness of breath, coughing, because too much of fluid can lead to what? Pulmonary edema. Pulmonary edema, we can cause the chest pain, the shortness of breath, the coughing, and so on and so forth. And of course, they will tell you that, oh, my feet are swollen. That is called what? Patent edema. Patent edema may be there. Patent edema. That is what? Indentation which remains after pressure is released from the swollen skin. So when you apply pressure, everything, there'll be what? Indentation. There'll be indentation. So that's what, which is actually good, okay, compared to the non-patent edema. In a non-patent edema, it means that the lymphatic system is now involved. Okay, but with the patent edema, that means the lymphatic system is okay. Everything is fine with the lymphatic system. Good. So these are what the symptoms again: yellow body, yellow eye color, abdominal pain, foamy urine, difficulty breathing, patent edema, increased heart rate, aching joints, difficulty lifting arms. If it is complicated with pulmonary edema, you are thinking of chest pain, shortness of breath, coughing, etc., etc. All right. What will be your drug of choice for his treatment, and give its side effect? So definitely there's too much fluid in this person. So what you want to do is to give a force diuretic. When I say a force diuretic, it will immediately take the fluid out of the system. The person will start peeing. So over here, we are looking at what? At a loop diuretic. And to be specific, we'll be dealing with what? Furosemide. All right. What are some of the side effects? Because it's 2-in-1, drug of choice and its side effect. So side effect of furosemide include hypovolemia. Because definitely you are drawing the fluid out, isn't it? Fluid out of the body. So it can lead to hypovolemia. And again, one thing is that as soon as fluid is moving out, potassium will start following. So we have what? Hypokalemia. That means low potassium in the blood. Hypokalemia. Then hyponatremia, because both of them will start going out. Hyponatremia. Then we have hyperuricemia. That means uric acid will be higher. So guys, take note. Uric acid will be higher. Hyperuricemia. But we have hypovolemia, hypokalemia, hyponatremia. Okay, so these are, some of the side effects. And that is why when people are suffering from gout or acute gout, okay, acute gout is because there's too much of what uric acid, which then start taking place or start acquiring the joint area, especially the big toe, isn't it? So over here, you will not give furosemide. So it is not advisable to give an hypertensive woman or somebody, a furosemide if the person is suffering from gout. It is contraindicated. It will rather make things worse for this person. So please take note of that. And sometimes you can hear what ringing in the ears, ringing in the ears, ringing in the ears. All right. So basically, these are what you're going to be looking at for in this question. All right. Once again, we've come to an end of yet another wonderful session. I hope you enjoyed it. Whatever be the case, let me know what you think about the video in the comment section. If you have a question, please don't hesitate to write it down. And when we get time, we'll meet together to answer some questions live. All right. So until then, see you in the next episode or the next tutorial. Peace out.